This is Neuro Thursday, part 6. Welcome back. Do we have somebody listening? Yes, we do. And I want to go back a little bit. We have had 5 Neuro Thursdays so far, and we're going to have, I hope, quite a few more over the next months and maybe years. And we're going to be talking about a whole bunch of different issues about functional neurology. So I just want to go back to some basics. I have discussions about some basics about medicine in general. We had this talk about, I think it was the second session we had this talk about dysfunction, what dysfunction is, what that means. And we have a whole bunch of modalities like osteopathy, chiropractics, they're using this word dysfunction. We have a growing part of medicine that call themselves functional medicine. So this is something that is able maybe to unify or bring together different modalities like osteopaths, chiropractors, nutritionists, etc., that have something to do with regulation. Also, acupuncture might be in that way thinkable in that realm of functional medicine. So, bringing all these together, those different philosophies would probably be called functional medicine, and that's what's happening. So, people in the United States and also in UK, I see that. Not so much yet in Germany. So we have this growing part of medicine that's called functional medicine. I think in Germany we still talk a lot about regulation, regulatory medicine. So that's the term we kind of like to use, but I think functional medicine would be better. So if we have function, we have dysfunction. I talked about the aspect that they're saying 50% of the people coming into practice, and I would say I'm not a general practitioner, but I have a general practice because people come with digestive disorders, with sleep disorders, with hormonal disorders, with headaches, with backaches, with all these kinds of issues. So I see about everything, and of course I see a lot of things that normal medicine can't really take care of because they don't have any tools to diagnose and they don't have tools to treat it because it's a functional problem. It's not a biochemical problem. It's not a structural problem. There's nothing you can cut away or cut out. It's a functional problem. So we have to be able to deal with this. And I'm just going to say hello to everybody who's listening and thank you for watching. We talked about what is a dysfunction. And of course I've been doing functional neurology. I'm coming from medicine. I studied medicine. I'm an MD, medical doctor, and so we have these people with functional problems, but we have no tools to diagnose it and treat it. So I went into chiropractics, chirotherapy, like we call it here. I went to osteopathy. We all talked about dysfunction, and I'm saying, well, what is a dysfunction? Yeah, well, it's a subluxation of a joint. It's a misalignment of a joint. It's a tightness of a muscle. It's a hypertone muscle, so it's a muscle that cannot contract correctly. All these things. But the question is what's behind it. So we talked about functional connectivity. And that's, I think, one main aspect I just want to go back to for a moment to talk about this aspect of can systems connect to each other? So if my brain wants to talk to my body, my brain needs to be able to connect to my body. And the connection is called functional connectivity, or it's also called coherence. We talked about cortico-motor coherence in terms of the cortex picking up signals from the periphery or synchronizing signals from the periphery to be able to connect and transmit signals from the brain to the body or from the body to the brain. So it's synchronous communication. So there is an electric charge in the cell, in the brain, and an electric charge in the cell, and that is not a constant charge, it's a fluctuating membrane potential, and so they can communicate, they need to adapt to each other or synchronize, and then they can transmit information. So I think a lot of what we're doing goes into that electric aspect. So it's not biochemical, it's electric, it's an electric issue. Of course there's neuroplasticity, and of course you have to train some things. You have to train systems so they work properly. Nothing goes without training, and every day getting up out of bed and going to work is training. So once I stop doing that, my system is going to start to deteriorate. So it's not a given that I can just lie around and do nothing. My brain is going to deteriorate once I do that, because mainly it's for movement, it's for action. So that's what it's there for. So then it has to connect and it has to be trained every day. But I might not have to do a specific training. First thing I take care of is connectivity. So that's what we're here for. So basic aspect of connectivity is to test for connectivity. And I keep having discussions about how safe, how maybe not safe, how reliable is that testing. Yeah, so I'm touching the body, I'm using muscle testing, and there's a whole thing of the muscle test, it's very subjective, it's very unreliable. So well, it's better than nothing. So I can test something that I cannot test in any other way. I do not have a machine who can test those signals I'm testing. I do not have any other ways of testing that functionally. Of course, movement, I can test and see how somebody moves. But how do I test for autonomic dysfunction? How would I test for a vagal disturbance in my gut? How would I test for that? And there I must say, using muscle function as a signal, or as a signal to me as the person who's treating the patient, that there might be something wrong between the gut and a certain part of the brain through the vagus nerve. Thank you very much for giving me that signal, and I'm very aware of that. This testing is my subjective interpretation. It's faulty, like all other tests on Earth. An X-ray can be done in a wrong way. A blood test can be done in a wrong way because I'm using too much pressure on the arteries. There's too much potassium going out of the cells, so everything is kind of distorted. So all these things can happen, and yes, everything we do can have mistakes in them, but I don't care, because I can get enough information out of it that I can treat the patient, because that does not have a consequence in terms of when I test this now, then I'm going to go to a tooth extraction or cut off the leg, do an amputation or something like that. I don't do that. All I do is, I might have a bad signal between A and B, and I need something to show me the bad signal, and I also need something to show me a better signal, and then I can integrate that. That's what we want to do, integration. So, and if you are interested, and we don't have that ready yet, but we have it ready actually, course 1 of our curriculum is going to be completely free on our online academy very soon. I hope after Easter we'll have that ready in English. So we have videos showing you how to go about it, and we have a whole script with all the contact points explaining where you have to touch to do this, or where you have to touch to get that, and then you can connect that. And the basic connection is just putting 2 points together and integrating them. So that's a very simple tool. And every day I have patients with the most astonishing, I might say, issues in their lives. I had a little boy, I think 10 or 11 years old, started out with cramps in his legs, and it went to epilepsy. So he developed an epilepsy, and the question is, why did he develop an epilepsy when he was like 12 years old? Why is that? So we started looking for problems. Of course, we also looked at labs. We did some lab testing, things like that, but I also looked at dysfunction in his body, and he had autonomic dysfunctions in his neck concerning the blood supply to his brain. And that's a bad thing. If you have an unstable brain situation and you have unreliable blood flow to the brain, you might get an energy problem in the brain. If you have an energy problem in the brain, you might have an unstable inhibitory system. And inhibition might be the more important part of the brain, because neurons like to fire all the time. If they are not inhibited, if there's nobody to make them shut up, they might just fire on, and if the firing spreads through the brain, then you have epilepsy. And we know that epilepsy is probably also caused, not solely caused, but also caused by energy supply problems in the brain. So that destabilizes the brain. You also have that in migraine. Cortical spreading disease, it's called. So there's a charge change or something happening to the neurons where they're not inhibited anymore. So inhibition is a very big thing. So I did testing, we did lab testing, and we did functional testing, and I don't know what did it in the end. Could also be just by chance. After 3 treatments, he did not have an epilepsy since then, and this has been since September 2020. So now we have March, almost April, so it's half a year, no more epilepsy, maybe due to this treatment. And then I'm saying, wow, if my treatment made the change, if my functional treatment of the autonomic system supplying his brain was able to make that change, and all I did is touch certain points and activating the nervous system, then I must say, well, thank you for giving me a muscle testing to determine system defaults, and thank you for giving me an integration so I can change that. Those are situations, and that's not the only child I treated with epilepsy. Those are situations where I say, thank you for this simple tool, very simple tool. Yes, and I probably make a whole bunch of mistakes testing and all that stuff, but in the end it might be enough to change a person's life. So I say, go for it. Don't wait and think about, this might be not very reliable or something. Well, if there's no other way of changing somebody's life, I'd rather take something maybe very unreliable than have nothing at all. That's what I want to say at this point. So going back to where we are, say patient is coming in, and what you can do, patient is complaining about knee pain, maybe in the front of the knee. So all you might want to do is touch that spot where he's experiencing pain. So you're interacting with the sensors in this spot, and you're also interacting with the motor control by then testing the muscle. For example, the rectus femoris. So I touch the knee and I test the muscle associated to the knee, hip, knee system, and I see if it inhibits. Maybe it inhibits right away. Maybe it only inhibits when I touch the knee first. Maybe it doesn't inhibit. So the next step would be, maybe I need to find a line. Maybe I need to find something that's going from A to B. So I touch the knee and I touch the back. So there I might only have to consider, am I in the front part of the knee or the back part? Front is L4. Back might be S2, S3. So I have to find different parts of the connective system. The more autonomic part of the knee is higher up. It's the lower thoracic spine, so I have to go up there. And so I might find an inhibition of the muscle when I touch 2 points. The part that's hurting and the part that it's connected to through the nervous system, spinal cord. So if this gives me an inhibition, and you can do that every day in your practice. Have somebody with an arm, elbow pain, touch the elbow, nothing happens, touch the elbow and the spinal cord. You have an inhibition, just go ahead and integrate it. Integrating up here on the parietal bone. Why that works, nobody really knows, but it has worked for 30 years. I've been doing it for 18 years, and I'm doing it, I did it yesterday, I did it today, it worked yesterday, it worked today, it's probably going to work tomorrow, and I hope it's going to work in 2 weeks when I come back from my Easter holidays. Well, I'm not going anywhere like most of us, but I'm going to take some days off and think and read, of course, about neurology. What else would I read about? Okay. So very, very, very simple. Touch, touch. It's like interfering with different parts of the sensory motor system. And as soon as you interfere with 2 parts, you might get a feedback from the system saying, well, that's too much. I can't understand what's going on anymore. So then I'm just going to say hello and thank you for watching here. Great to have you. So knee, back. Inhibition of the muscle, integrate. Knee, back, integrate the parietal system or the parietal bone. Go tap on that for a couple of seconds. Retest, and then let the patient do some movements. It could be that the patient might say, well, that's weird, it feels better already right now, just by touching, integrating. Yeah, so that's how simple it can be. Not much thinking about all the mechanics and all the different structures. Just activate a nerve, activate a nerve, and activate a nerve. Okay? So I would like to invite you at this point, if you haven't done any courses with us, if you haven't done any seminars with us, we haven't done any seminars in English yet, but we're going to do that starting hopefully next year. So just try that. Where does it hurt? Touch it, test. If it doesn't inhibit a muscle, touch and test. Okay, very simple. So what we want to talk about today is a little more complex aspect, one that is really something I need to talk about because I believe that more dysfunctions are due to interoceptive visceromotor problems. Less dysfunctions are actually really have to do with sensory motor issues. Okay? So I just want to explain that, why I think that is so. And here we go. So we have the brain. We have the brain stem with the pons, with the medulla and the cerebellum. And what we have underneath, I'm going to draw that a little bit bigger, is the spinal cord. Okay? And we have nerves going off the spinal cord, and we might have a muscle right here or on the other side, whatever. Okay, so what we thought about 4 weeks ago is like activating sensors in the tissue, in the muscle, or in the periphery, in the skin, in the fascia. So we're talking about vibratory stimulus and how that could activate certain tracts to the brain and how we could work with those. So now what we want to think about is what's happening to the signal when it's being processed. So one aspect we have to put in here, and I'm just going to take a red because that's what this can represent nicely. We have the heart. Okay, so the heart is pumping blood all over the body, we know that. And in the blood we have sugar, we have fat, we have oxygen, all those things that we need. The muscle in normal function would use fat mainly to burn, so we need to get fat to the muscle and we need to get oxygen to the muscle. We need to get that into the mitochondria to produce ATP so the muscle can work. One thing I just learned, and I think that's very interesting, I studied medicine, 30 years ago I started studying medicine, and I just learned a couple of days ago that the muscle needs more energy to relax than to contract. Oh, that's interesting. Never thought of that, but it's kind of makes sense because if somebody runs out of energy, he gets a muscle cramp. It's not like the muscle is going loose, it's cramping. So, there we go, no more energy, I can't let go anymore. That makes a whole bunch of sense. So, what's happening here is we have autonomic nervous system running next to the spinal cord, and here we have blood vessels going to the muscle, of course, supplying the muscle with blood. And what we know now is that this signal is not even going through the central nervous system. So trying to find, or always trying to think about the brain, insula, brain stem, because of interoceptive visceromotor issues is wrong. That is just wrong because a lot of reflexes are just going through the peripheral autonomic system. So one reflex would be, for example, the exercise pressor reflex. So once I start moving my muscle, I don't even need a dropping oxygen supply being signaled. So saying I better need oxygen right now. As soon as I start moving my muscle, the heart's going to start pumping more. Exercise pressor reflex. A failure of this reflex is associated with congestive heart failure. So training this reflex by moving might be helpful, and yes it is. People with congestive heart failure train their system every day, light training of course, they can get better heart functions probably through reactivating exercise pressor reflexes. So, but while this is going on, and this is what I want to get at, is we have this system right here. So what is this system right here? The spinal cord is probably mainly movement reflexes. So sensory motor reflexes, gait reflexes. Mainly we have the central pattern generators that are sitting in the spinal cord supplying the muscle with information. But while it's doing that, it also needs oxygen. So there's also a blood supply going to the spinal cord, of course. And if you haven't done that, I want to invite you to check out an anatomy book with the view of the spinal cord with all the blood vessels. If you haven't seen that, you might be astonished how much blood vasculation, is that what you say? How many blood vessels you have there in the spinal cord area. Well, it uses a lot of energy processing information and supplying information to the legs by activating the muscle and relaxing the muscle, activating and relaxing. So the muscle needs energy, the spinal cord needs energy, the spinal cord needs blood supply. So I have this patient coming in last week. She had bad low back pain last year with radiating pain down the leg, with movement disorders. Maybe she had a disc, a bulging disc or a ruptured disc or whatever pushing on the nerve, but with normal therapy everything went back to normal quite fast, or normal therapy of course also integration. And she came back and now she just had low back pain, really deep, really like bad feeling. So we're thinking about muscle, we're thinking about joint stability, we're thinking about proprioception, we're thinking about vestibular system, all those things. All tested all that, nothing really showed. What did show is a autonomic problem in that area connected to the autonomic system of the heart or the vascular system. So once we dug that out, well, didn't have to do too much digging. Once we found that, and once we integrated that, in the process of integration, she already noticed that now her back was opening up, relieving the pain was going away in the instant of integration. So she was lying there, I was testing and I was integrating it, and there she said, now it's opening up and now the pain is going out. So maybe she had a vascular cramp. Maybe she had what we call a neurovascular dysfunction. So neuromuscular dysfunction, neurovascular dysfunction. There also could be a neurolymphatic dysfunction. So this was a neurovascular dysfunction in the spinal cord. And that caused her problems. And of course, if you have a problem in the spinal cord, and that's what I want to get at, don't always think, oh, maybe it's coming from the back. Maybe somebody comes in with an EPA, that could be the back. Well, what part of the back? The muscle, the joints, the fascia, the dura, or maybe the spinal cord? You need to think about the spinal cord. Especially if somebody has like a history like, oh, I fell off the horse and I fell on my pelvis and I kind of crunched my back, and then now my knees are hurting and my hips are hurting. It could be a problem in the spinal cord through a neurovascular problem in that area. So I want to show you how I would test that, because it's actually quite easy. You just need to know where to go to. And of course, I don't know when I work with that patient who felt the relief of the pain right when I was integrating it, if I really was treating the vascular system. Of course, that's a model. I did not do any blood flow measurements. But why would I test with the autonomic nervous system of the heart or the vascular system? Why would it release once I integrated that? Who knows, to be honest. Okay, so my son is here and he's going to help me on this. And thank you for joining us and watching. So, this is my son, and he might not have anything. So if I test him, and he doesn't complain of any pain right now, so I could just test him from the viewpoint of the spinal cord. But if a patient would come in and say, I have a knee pain, I would first of all see if touching the knee, let's say he has a left knee pain, touching the knee would cause anything. So I would also test lying down, because then I can get closer with a sensory motor testing closer to that part. But sometimes through the gait patterns and other connections, and I'm not talking about fascial or muscular connections, I'm talking about neural connections, you still, or very often you get also an affection of other parts of the body testing. But if I see somebody testing only with one arm, saying I'm testing everything through the left arm, saying, well, that's not going to show you all the information. That's just going to show you one part of the information coming from one part of the brain and going to one part of the body. So we have 4 extremities. I always look into the 4 extremities, and I usually look into the extremity that's affected. So I'm not doing that here because we're standing up and we're just showing that right here. So I'm testing him, and we're going back to basics. Does the muscle facilitate? Does it inhibit when I touch the spindles? So that should happen. Too much focus on muscle activation, not enough focus on muscle inhibition. So what do you see more in patients? Somebody coming in with a tight muscle or with a loose muscle? A lot of people complaining about pain saying, oh, I have a tight muscle, and you feel it and the muscle is tight. So the muscle is not able to inhibit properly. So too much focus on muscular activation from my point of view. So he can activate the muscle. I can inhibit his muscle through a spindle test. I can just go on the muscle spindle. That would inhibit. I touch his knee. Yeah, he says, I have a knee pain lateral. So you just touch it, no big thing, and you test and nothing is happening. So you can still hold the muscle. So then I would go to the knee, and then I would also go to the back. So you can do this in a timely fashion in terms of do that together. At the same time, hold his back, touch his knee. So you have 2 sensory interferences with the sensory motor system in the periphery and central nervous system in terms of lower back. So I might be down here, L4 or something, and I might touch his knee, and I might touch his back, and this might inhibit. Okay, this might give me a signal, an information about there's a problem correlating to the leg and the spinal cord. So now you could integrate that. That could work. So just going to the knee, going to the spinal cord, and going to the integration part of the head, I want to say, not the brain, the head, could change the way the knee functions. You can try that. That's very, very easy to test. Is it 100% reliable? Of course not. It's just one way of getting some information out of the body, other than let him walk, let him do some squats or whatever. It's a different way of getting some information out of the system, and I can use this information right away. I have a nerve fiber from his knee to spinal cord, and I can just integrate, and that might already change the function of the knee quite a bit. Maybe only 5%, maybe 50%. Who knows? Just get some feedback, let the patient walk, see what he feels like. Okay, so if what I would do first, though, before I would integrate this part, I would check out the spinal cord, because I always have this idea of I want to check out the central nervous system, how that is working, because it might be more central, especially if somebody comes in and says, both of my knees are hurting, or both of my hips are hurting. So that would probably not be a biomechanical problem in the knee. And what I hear a lot is that the people are asking, well, I've been told that this could come from my back. Well, I'm asking, well, which part of the back? Is it the spine, or is it the spinal cord, or the muscle, or what are you talking about? It's coming from my back. So of course it can come from your back, because that's where your systems are sitting that are regulating the muscle tone and the muscle function in the legs. So what I would do is I'm interested in the autonomic function, because I've learned that a lot of people, even if they had a trauma, they fell off the horse or off the bike, and they had some trauma to their pelvis or to their spinal cord, and then get knee pain, I would not expect too much be happening at the knee from a functional perspective. So that's where I start. And very easy, if I have established a dysfunctional connection between maybe the knee and the spine, I just leave the knee alone and say, well, I'm just going to look at the spine. Okay, and the first thing I do is I want to test the connection between the spinal cord down here and the vascular system through the autonomic system. So going up here, where the autonomics of the heart would be, the sympathetic of the heart, is too unspecific. Much more specific if you go right here where the heart is, because you have parasympathetic ganglia right here at the heart. You also have the sympathetic nervous system right here at the heart. So you have both, and what we mainly need, if we look at that, if you look at a vascular system, we need the sympathetic nervous system, but this of course could also be something else. This is more specific. So all I do, and that's what I did with that one patient I just talked about, all I did is touch that part that's hurting. Where does it hurt? Ah, there it is, okay? Touch that part where it's hurting. If it's the knee, I have to find that part that might be dysfunctional first. If it's hurting in the back, I can just go right there. And then at the same time, before that, of course, I do this. I touch and see if something happens. Here, leg, any muscle that goes weak, that weakens, that gets inhibited by touching the spinal cord. Maybe yes, maybe no. If not, then I start connecting pieces, okay? So I'm at the spinal cord, I'm down here, and at the same time, I'm up here where his heart sits and where he has the autonomic nervous system of his heart. So you might want to get a little bit of pressure on here, just slightly. You have the contact in the back on the spinal cord, and then you test. And if that inhibits a muscle here or in the legs, that might be, I'm saying that very directly, that might be interpreted as a dysfunctional connection in the autonomic nervous system between the regulation of the spinal level, the segment, and the vascular system. So maybe I would interpret that as a neurovascular problem in the spinal cord. So, and then, very simple again, I can go back and go right there and integrate that. So it's just two contacts activated through the central nervous system, or maybe it's not the central nervous system, maybe it's also here some autonomics connecting the body here through the autonomics. That could be. We don't know what this is actually doing. We just know it's doing something. So just by doing this, and this is what I did with that one patient lying on my table, and she's saying, now my back is opening up and now the pain is going away. I just was doing this and this and this, basically, okay? Too simple? For some people that could be too simple, saying, oh, well, that's, I'm just touching here, touching there, and I'm integrating, that's it. Say, yeah, well, I'm not the specialist for how much blood flow that part of the spinal cord is going to need at this moment. That's the brain. I just need to connect those points, okay? I'm the telecommunication center, okay, helping communication between autonomic central sensory motor parts of the system to connect. And yes, it can be that easy. And I would like to promise you, if you try that on your patient tomorrow, patient coming in has a back pain somewhere, and you're just touching that part of the body, and it could just be anywhere. Of course, if you go up here, you don't only have the vascular system of the spinal cord, you also have the autonomic system of the heart. So could be both things, but if you're down here, this part does not innervate the heart, but there is blood vessels in this area, so this part through the blood vessels needs to be connected to the heart to change the blood flow here when I start moving my legs, because when I start moving my legs, I need more energy in my legs, and I also need more energy in my spinal system to do all the calculating, okay? So I want to promise you, if you do that, if somebody comes in and says, oh, my back is hurting, you go on the back, you test the muscle, nothing's happening, you go to the heart, and those two contacts in the back and the heart would inhibit, and you just integrate that. Hold here, hold there. So you hold here and you hold in the back, and you go to the head and you integrate it. That might change a little bit, or it could change quite a lot. So I'm just inviting you to try that out. I think the vascular system is maybe is it the most important part? Probably yes, because everything else is around getting some nutrients out of the food into the system, getting them into the blood and transporting them to the system that needs them. So in all the biochemistry, the vascular, maybe also the breathing system, but the vascular system is the distributor. The lymphatics are quite important because they're taking away a lot of garbage from the system, from the muscle or from other tissues, but getting it there, getting oxygen there, getting sugar, getting fats there, being able to put those nutrients into the mitochondria, producing ATP, using them for contraction and relaxation of the muscle, and using them for calculation, how much contraction, how much relaxation in the spinal cord, or just putting out the patterns and I'm walking or I'm running. That's a very central issue in everything that we do. Talking about autonomics, it's very much about the vascular system. So what I'm just going to do, just for fun, I'm going to test my son's spinal cord relating to his autonomics of the chest, of the heart. So I don't know if he has anything. I'm just going to the spinal cord, to the cervical spine, just testing something. There's nothing showing up here. This could be also a neural connection from the spinal cord to the heart. So there's nothing going on all the way down here into the sacrum. So don't forget the sacrum. At least I'm going to test the other side. Okay, so I'm doing the same thing. Other part of the brain, other part of the nervous system. I cannot rely on one side of the brain telling me the whole story of the body. And of course, I also cannot rely on testing just arms. Okay, hold very strong if you can. Okay, so that was just not paying enough attention there. That's normal, that happens. Just retest. I have people in the seminar, they do one test and they say, I'm not sure if there was something there. Just retest. Sometimes I test 3 times to be sure what was going on, because the patient's maybe not paying attention. It feels like it's weak, but it's not weak. It was just not paying attention. So retest, 2, 3 times. No, there's nothing there. It's all good. Okay, hold strong, good. So my son, unfortunately, I want to say, does not show anything in his spinal cord. So what's going on here? I'm saying hello. I'm saying hello. Thank you for watching. So this is very simple, and I realize there's something in the brain saying like, well, if it's really complicated, I believe it. Yeah. Oh, that's too easy? Yeah, that can't be true. So we had a lot of experience about that, about patients saying that, about people in the seminar saying that. Well, you're just touching here and you're just touching there and then you're touching here and that's it. That's all I do. So, yeah, well, sometimes that's all you do. Sometimes it's just the specific connection I have to find that's not working correctly and I have to integrate that. Sometimes it's that simple. And if you can't cope with simple, okay, then you can't cope with simple. If you want it simple, you don't have to manipulate the spine. You don't have to do 10,000 exercises to do that. You might only have to integrate one area with the right partner in the system for a couple of seconds, and that might not resolve the whole thing, but change a whole bunch of things, okay? So, one more time. Your patient is coming in tomorrow. You're saying good morning. So, you're saying good morning. That's already also a muscle test, by the way. You can, and you can test the pulse. No, here, put the finger on the pulse, saying, okay, I got the pulse. I checked that. I can already write a bill for that. Shaking hands, muscle testing, functional test of the arm, testing the pulse. Okay, that's the first thing I do. Okay, test the muscle. Hold very strong. That's very good. Hold very strong. Yeah, that's also very good. And are you able to inhibit? Is the inhibitory system turned on? Yes, he is. Is that relevant for the testing? Not really. It just gives me a feeling for how well does he facilitate, inhibit. So, next step. Where does it hurt? My neck is hurting. Okay. If I touch your neck, does that do anything? No, it doesn't do anything. I'm just going on the back of the neck, okay? So I could also do something like this. This would be like a little more of the neck, okay? Could also do something like this. Nothing is happening. Next step would be go to the spinal cord, go to the heart, okay? Ah, there it is, okay? So this is not happening. I'm just showing it, okay? Next step, this, integrate, okay? And this could be improving like the signaling between different parts of the body, and the central vascular system could change quite a bit already right there. All right, that's where we are. And I want to say thank you. I want to say hello, and I want to say thank you. You can watch this. You can watch this anytime. We recorded it. You can go to our YouTube channel, Neurolog Academy TV, and you can watch there. It's all recorded. Also in the other format, we have another camera standing here. We are live on Zoom. Also, if you want to join us on Zoom, we can have a discussion at some time. We'll be back in 2 weeks. We'll talk about segmental anatomy, about connections between different parts of tissues, skin, bone, glands, muscle, all those connections, autonomic connections, why they interact, What does that have to do with pain in the knee and problem in the gut? Stuff like that. That's what we'll be talking about. Thank you for watching.